Welcome to Eye Contact. I am José Güell. Today I am joined by Dr. Serge Doan, who will talk to us about ocular surface disease diagnosis and management. Welcome, Dr. Doan. Welcome, Serge.
Thank you, José.
How does meibomian gland disease affect optical image and acuity? I know that this is a long topic, but try to explain to us the main tips.
The regularity of the tear film is capital for refractive performance, and in fact, in the tears, the meibomian glands provide the lipid layer, and this lipid layer is capital for the regularity of the tear film. So it's in patients who have MGD, they often complain about fluctuation in vision, and this is related to instability of their tear film. So it's very important to have this in mind when you make cataract surgery or refractive surgery in those kind of patients.
And you need to take this into account for in your preoperative evaluation and also in your postoperative evaluation of your patient, isn't it?
Yes, for sure. I think we don't have the habit to evaluate the patient. There are so many things to do preoperatively, explaining the benefits and risks. So probably some of us or many of us don't have the time to examine the ocular surface, to see the stability of the tear film with the breakup time, or to see if there is any staining with fluorescein, or to examine the blinking or the lids. But it's in fact, when you see the post-op patients who are unhappy because they have dry eye or because they have unstable vision, especially after multifocal lenses, then you realize that those patients in fact had pre-op problems of dry eye, mainly MGD in fact. So it's probably very important to examine these patients and to keep maybe 1 minute to look if there is any pre-op dry eye.
And how does MGD impact in your preoperative measurements? And I'm saying not only in cataract surgery, but also in corneal refractive surgery.
So in cataract surgery, it can impact in the measurements, for example, in the biometry. When you do the biometry, you know that the regulatory of the tear film can change the keratometric measurements. So in a patient with MGD, but not only, also aqueous deficient dry eye, it means quantitative dry eye, you can have a false biometry just because of the of this problem of tear film. So how can we detect pre-op dry eye? Well, it's very easy in the clinical practice. Just a breakup time for sure. I think it's probably the easiest way to detect an unstable tear film. Schirmer, I think is not useful, but you can just look at the meniscus, the tear meniscus onto the inferior lid, and if it's very low, you can probably know that you have a problem in quantity of the tears. Then with the fluorescein, you can of course look at the staining, and probably if you have some staining on the cornea and on the conjunctiva also, the fluorescein, you know that it stains also the conjunctiva. If you have this staining on the conjunctiva, then you know that you have probably a more severe dry eye that you thought. And I think it's also probably important to look at the lids, at the lid margin, and to press the meibomian glands to see how the meibum goes out, if there is some obstruction of these glands, and also look at the inflammation of the lid margin, because if you have inflammation of the lid margin, especially anteriorly, then you have blepharitis and not only a risk of dry eye, but also an infectious risk.
You evaluate the breakup time yourself, I mean subjectively, so you verify and count seconds until in the standard way, or you use any instrument to evaluate it?
Yes. Well, I don't work with optometrists, or so I do the manual breakup time. But for sure, in ophthalmologists who are organized with optometrists or orthoptists who can do examinations before, it's probably better to have a non-invasive breakup time, for example.
Okay.
Yes. But also, I think it's probably important to have today to have those imaging machines for mammography, for example, because more than non-invasive breakup time, I feel that those new techniques that allow you to investigate the mebum, and the meibomian glands are very important because you cannot see them otherwise. For example, mammography allows you to have a look on the meibomian glands, so you can see how they are, how many are there, if there is atrophy. And last week I had a patient who complained about very severe dry eye after cataract surgery, and I did made the surgery myself. And I made the mammography. He had still the meibomian testing, so when I pressed the meibomian glands, it was normal. But when I looked at the mammography, he had a major meibomian atrophy. And this explains why. And there is probably a second examination that can be interesting, is the interferometry of the lipid layer. So you can see the thickness of the lipid layer, which is the functional, morphological parameter of the lipid layer that you can see pre-op in these patients.
And when you find that the ocular surface and you are in front of a, let's say, clinically significant MGD problem, you want to treat it before the surgery? You want to start treating it before the surgery?
Yes, of course, of course. Well, the first treatment, I think, is prevention and also information. The most unhappy patients are those who you did not tell anything before the surgery. And if you, in the interest of screening those patients for dry eye, is of course treating them before, but also making information and telling them, okay, you have dry eye, you have MGD, and you are at risk of developing dry eye after the surgery, even if you don't have any symptoms before the surgery. And then he can understand this, and he will do the treatment that you prescribe him. So in terms of treatment, well, you have several strategies, but I think we should keep simple. And in terms of MGD, the most simple treatment is lid hygiene and lid massage. Warming of the eyelids for 5 minutes and then massaging the eyelids, and then use artificial tears, especially with lipids, if there is MGD and stable tear film. So you can use those your favorite emulsion eye drops. And personally, I don't like to use antibiotics before the surgery because I feel that it can change the flora and can select some resistant bacteria. So I think it's not a good idea. Post-op probably it can be interesting, but pre-op I'm not sure it's a good idea.
It's a good idea, except in those cases where you possibly recommend to use oral because there is a kind of associated rosacea or something like that.
Yes,
okay.
Yeah, for sure.
And in the post-op period, do you recommend then sometimes to add antibiotics, but also do you recommend either both preoperatively and postoperatively any local treatment with devices that will give massage, or do you use the laser? Which is the let's say the position
yes.
of these instruments for you?
Yes. Well, post-op, every patient I do the surgery do have artificial tears. Of course, you cannot do the lid massage right after the surgery, whether either cataract surgery or especially refractive surgery. We cannot press the eye, and there is a concern about the lid massage after LASIK patients. We don't know how to do the lid massage, in fact. but usually that's all. In most severe patients who come after the surgery and complain and have a persistent complaint after the surgery despite the treatments, then I think it can be interesting to perform some modern treatments of MGD. So I think about the pulsation therapy, which is today the LipiFlow, but there is another technique that comes, which is called what's the name? I don't remember.
Well, there are several. There are several in the market, yes.
And it can be interesting, but you have to be sure that it's MGD. So the principle is to perform the massage automatically, and the LipiFlow is very interesting indeed. And there is another technique, which is the IPL. It's an intense pulse light therapy, and the principle is to flash with the white light. You flash around the eye. Patients, especially who have MGD, we really don't know how it does work. In fact, it may have a thermal effect, a neural effect, an anti-infectious effect, and a warming effect. We don't really know, but it's quite intriguing to see how the effect it has on many patients. So in those patients, in those patients who have dry eye after surgery, it can be interesting to try also IPL, the intense pulse light therapy, which is complementary to those LipiFlow because it does not have the same mechanism of action, clearly.
Okay, so anyway, what we both agree is that taking care of the surface before and after the surgery is mandatory today. No, because a number of cases that have a significant known or unknown dry eye is high. No.
Yes, clearly. Yes, we made a study, and there are several studies in the literature on the cataract population patients, but also in refractive surgery patients. You know, those patients who come to your consultations and say, "Okay, I cannot wear my contact lenses anymore." This is a warning. This is a warning because they have either allergy or dry eye, and mainly MGD in those young patients. So it's probably very prevalent. So we should have an eye on it.
Thank you very much, Serge, for joining us. For more information, please visit us at eurotimes.org.